Okay, welcome students. Chapter 8, Lifting and Moving Patients. Here we go. All right, so lifting and moving patients. You're going to be doing a lot of this. You've got to be physically fit enough to take care of your patients, to get them off the ground, out of a ditch, out of the bed, from hanging upside down in a car, whatever the case may be. You've got to get them prepared for transport. That's one of your number one things as an EMT, is to assist as part of the team to get this patient ready to go. So, typical call, you're going to have to move patients several times to be able to provide them care. At a minimum, you're going to have to be able to lift and carry the patient to the stretcher, and then move the stretcher to the ambulance and load the stretcher into the patient compartment. Nice thing is these days is that the ambulance stretchers, 90% of the EMS agencies now have a electric lift system that puts them in the ambulance. And then, of course, at the hospital, you got to be able to transfer them from your stretcher over to the hospital gurney. To move patients without injury to the patient or yourself or the team, you need to learn and lift correctly. You also need to know how to use, patient moving devices that are available in emergency medical services. We have lots of them. And then, of course, the dynamic processes of being able to carry everybody, work as a team together to lift at a team, so on and so forth. Performing these actions safely requires a good understanding of anatomy, body mechanics, and team dynamics, and patient positioning. One of the things that I'll tell you now is that I've had people that have worked for me in different agencies that I've been a part of that have injured themselves because of poor lifting techniques, and they're out of the service, period. They crush a disc, they herniate a disc, they rupture a vertebrae, whatever the case may be. I've seen at least a handful and a half of people that have ruined their career all because of bad body mechanics. So we're going to talk about all this. So patient packaging and handling are technical skills. You got to do a lot of training, you got to do a lot of practice, you got to remember those body mechanics. Good body mechanics will save your back. Fortunately, we have lots of tools, we all work together, and sometimes we have patients that can be excess of 500 pounds. That's a big patient. So you need to master these skills and make sure that you're able to move patients with ease and know your limitations and not injure yourself while you're on the job. So let's talk about anatomy and body mechanics. Okay, about the anatomy of body mechanics. When a person stands upright, they're bearing all the weight associated with gravity. Because remember, we live in a gravity, induced environment. All the weight is pushing down on your head. You're bearing all that weight, and it's your spinal column that does that for you. Let's take a look here. Your spinal column, okay, here, okay, is this structure, this bony structure that moves all the way from the base up to the bottom of the head, where, up at cervical 1, which is up at the foramen magnum underneath the skull. So, those vertebrae support your weight. And one of the things that's interesting is that this area here of the vertebral column is called the sacrum. It's the weight-bearing part of your spinal column. It's kind of like a microphone. If you know what a microphone stand is, it has the pole, and at the base of it, there's a round disc, and that round disc is heavy. It supports the weight of the microphone and then whatever the singer puts on it when they bend it back and forth, kind of thing, to bring it closer to their mouth to sing in it. So it's the weight-bearing base of the spinal column. Body mechanics have to be in relationship between the structures, the anatomical structures, the physical forces that are associated with lifting and moving and also carrying. So these areas need to be very specific on bearing all the weight and knowing how to use them properly. So with back properly maintained in an upright position, you have little strain that occurs against the muscles. and ligaments and keep the spinal column in alignment. Significant weight can be lifted and carried without injury. Now, looking at this photograph is bad. Looking at this position is a problem. He's leaned forward. He's going to get hurt, okay? His back needs to be upright. His shoulders, okay, should be in line with his pelvis, and the knees should be bent. He's leaning forward. He's running a risk of injuring the lower part of the back, somewhere between the lumbar and the sacral spine. It's just not going to work. Over a given period of time, he'll end up bulging a disc and he'll be herniated, then out of the business. So you may injure your back if you lift while leaning forward, as you see here. Lift with your back straight, but bent slightly forward at the hips. So lifting techniques. Legs should be spread about 15 inches apart. Place the feet so that the center of gravity is properly balanced, and the weight should be balanced on the balls of your feet, not your toes. And then with your back held upright, bring your upper body down by bending the legs, grasp the patient or the stretcher, and make any necessary adjustments in the location of the feet. Lift the patient by raising the upper body arms and straightening the legs until you're standing. Then curl the arms upward to waist height. Then you can lift by extending and flexing the legs, the safest and most powerful way to lift the patient. This is called the power lift. Keep the weight as close to your body as possible, okay? Usually if we keep it around our umbilicus, once we get them up high enough, your belly button, you'll be okay. Avoid placing the lateral forces across the spine and sideways leverage against the low back. Don't lean forward, don't lean sideways, don't do any of that. Don't twist at the middle. Always turn full body, whatever you need to do, because any unnatural motions is going to be hard on your back and potentially create an injury. So power grip. Notice the way the hands are loaded here onto the backboard. This is a special kind of board. It is actually a scoop stretcher that comes together right here. This is a Furno scoop stretcher. It's made from plastic. The ones that we have here are made from metal. They're about the same in as far as the weight, and they're conformed about similar as well. This particular one in this particular lift is going to lift this person straight up. Notice how his knees are bent, okay? He is in that power lift position where his legs, his thighs specifically, is what's going to be picking up the weight, not his back. Now, he's slightly bent forward, but he's not leaning forward. He's going to use his legs to come up with the weight. And this person on the other end is going to be doing the same thing. So another type of move is the body drag. Okay, it's to put them on a blanket, as you can see here. This patient has been rolled onto a blanket. You're going to do the same kind of body mechanics and principles for moving and lifting, carry the patient. So the body drag, you're going to keep your back locked in a slight curve, create a tightening abdominal muscles, kneel and extend the arms no more than 15 inches. Okay, then when you can pull no farther, then you have your hands reach in front of your torso, stop and move back another 15 to 20 inches. So again, this person stays in the squatting position. They pull, they back up, pull, back up. They're not lifting this person, they're dragging this person. This is one person, so one person is not going to lift this individual. They're dragging, they're doing a body drag. So alternate between pulling the patient slowly, flexing your arms and repositioning selves to drag this person to safety. All right, so safe reaching and pulling to continue. This is another type of drag. If you drag a patient across a bed, kneel on the bed to avoid reaching beyond the recommended distance. Drag within 15 to 20 inches. So if the person's in the bed, you're not going to lean forward like that and drag them this way. You're going to get up on the bed, drag them to the edge of the bed, then get off the bed to drag them onto the stretcher at that point. Or you can go from head to foot and drag them across that way. In the hospital, transfer patient from the stretcher to the bed with a body drag. You can also use what's called a slide board. You put the slide board in it, which is nothing more than a piece of plastic that fits under the patient. So it's halfway onto the stretcher and halfway onto the bed. And you're going to drag that person from the bed across that plastic slide board. They work very, very well. All right, so this is a log roll. This is where we're rolling a patient that needs to be put on some kind of transportation device. They're using a backboard at this point. There are 4 people involved. This person on the left, this person right here, is holding C-spine immobilization, okay? The person at the head is the person that's in control. The other 3, notice that they have the 3 points of the body. They have the torso, they have the pelvis, and they have the lower extremities. Okay, so when this person was laying flat on the ground, the person at the head holding C-spine counts to 3, and on 3, he gives the command to roll. And then these people have rolled this person over to their side. They will check the back just to make sure that there's no injuries. They'll do a blood sweep. They'll also look for any protruding or step-offs of the spine, those kind of things. And then they'll pull the board close, as you can see here. And then on his command, 1, 2, 3, they'll roll the patient back onto the board and then center the patient on the board by doing movements in an upward fashion and a downward fashion to keep the patient's spinal column in line. We're going to practice this, trust me. Review those skill drills because the skill drills are available to you for this chapter and how to do this. So make sure you review that before you come to class. All right, so safe lifting and carrying. Bottom line, whenever possible, use some kind of device, okay, that can be rolled to move a patient. When wheeled devices are not available, make sure you understand and follow the proper guidelines and get enough help. Patient weight. Estimated patient's weight before lifting. Do not exceed your limitations, okay? Minimum of 2 EMTs may be able to safety lift, okay? In the U.S., the average adult female and male weigh somewhere between 170 and 200 pounds, respectively. So 2 EMTs may be able to safety lift this weight. Consider using 4 clinicians whenever possible. You should know how much you can comfortably and safety lift and should not attempt to lift a proportional weight, the shared weight that you can bear that exceeds this amount. Okay, just don't do it. Make sure you have enough help. There's a stretcher that you see. This is a type of stretcher that is a high bariatric stretcher that can move patients weighing more than 350 pounds. Notice that it's in a lower position. There's handles to be able to, to position the EMTs on both sides. One will guide and one will pull. And the other one at the person is not only, the pusher. You have a pusher and a guider. The guider's at the feet, and the pusher's at the head. But yes, and notice that it's in the lower position to move. So if a patient is on this and you're rolling them through the hallways, this is the position they should be in. Being they're extra heavy, they do not need to be in the up position where their center of gravity is so delicately fragile. They'll fall over any type of seizure activity, or if they lean one way or another, the whole thing may come over. So danger, Will Robinson. Directions and commands. The team leader is the person that's at the head primarily. That whoever that person is, they're the ones that's going to be giving commands. Everybody needs to listen to that team leader, and you need to move the patients in a fashion that everybody's doing it together. So preparatory commands to the command execution is all a part of it to be able to move patients effectively. Patient positioning. Patient must be properly positioned based on chief complaint. A patient with no suspected injury, reporting chest pain or respiratory distress, should be put in a position of comfort, whatever works for them, typically a Fowler or semi-Fowler position. Patients who are in shock should be packaged and placed in a supine position, otherwise they're laying flat, so that you can elevate the feet to help them with their shock if necessary. Patients in late stages of pregnancy should be positioned and transported on their left side if they're uncomfortable, or if they're hypotensive when supine. An unresponsive patient with no suspected spinal, hip, or pelvic injury should be placed in the recovery position. You learn that in BLS. It's on their left lateral recumbent position so that you can manage their airway. A patient who is nauseated or vomiting should be transported in the position of comfort. Personal consideration. Ask yourself these questions before moving a patient. Am I physically strong enough to lift or move this patient? Is there adequate room to get proper stance? Do I need additional personnel for lifting assistance? Do not hesitate to ask. You don't want to get hurt and ruin your career. So ask these questions before you make the move. Emergency moves. So an emergency move is used when there's potential danger before assessment and care is provided. You're going to use this when you cannot properly assess a patient or provide immediate care because of the patient's location. Okay, so this is an emergent move. Move the patient on their back along the ground using one of the methods. Okay, pull on the patient's clothing, as you can see here. Not real reliable because, hey, the clothing could tear, that kind of thing. Or place them on a blanket. This is a good one if you have enough time. Okay. Or place your arms underneath the patient's shoulders and armpits, and then while grasping your opposite wrist, drag the patient backwards. That's in this particular photo here. Okay, notice he's locked up on the wrist, he's up underneath, so he can pick him up and drag him along the ground. And always recommended to get two people involved because, quite frankly, one person could lift, one people could grab the feet, or you could do a side-to-side kind of lift and carry. So whatever works, there's multiple carrying techniques. All right, so if you have a patient in an unconscious situation in a vehicle while you're alone, so you're by yourself on this, you've arrived on scene, for some reason you're by yourself, whatever, move the patient's leg clear of the pedals, okay? Rotate the patient to their back, okay, which is towards the open vehicle door. Place your arms underneath the patient's shoulders and through the patient's armpits and support the patient's head against your body. While supporting the weight, drag the patient from the seat. If the legs and the feet are clear, rapidly drag the patient to a safe location. Car's on fire, imminent danger, patient's gonna die. You feel that you're safe enough. I mean, look at this person. This person's got turnout gear on. So worth the risk, get the patient, drag them away before the car catches really and fully engulfed, and then perhaps even an explosion, from the gas or the fluid. So this is something that you're going to have to ensure that's safe enough, you feel comfortable enough, and you got some safety gear at least on to protect yourself in order to rapidly move this person out of a burning vehicle or out of a life-threatening threat for the patient. All right, so here's some emergency moves. Different one-person drags, carries, and lifts. Obviously, the cradle lift. All right, this is the fireman's lift. You've tied their hands together, the wrist, okay, and place those hands up over your neck, and then you're going to crawl your way out, dragging this person along. One-arm lift carry. This is a good one for somebody who's semi-conscious. They can still walk a little bit, even not much, whatever, and you can actually drag them along and get them out. This is the traditional fireman's carry. You just flip them up over your shoulders like that. Grab a wrist here, okay? This person is elected to grab, all the way around both legs. I generally just go through the legs to do my lift, and then I'm holding onto one leg and holding onto a wrist. Here, this is called a backpack carry. Just what it looks like, it looks like a backpack. He's plopped her arms up over his shoulders, grabbed her wrist, and is carrying her out of harm's way very, very quickly. Hey, whatever works, works. It's better than being shot or better than being blown up or burned up or that kind of stuff. So whatever you can do to make it happen, sometimes this is the way you just got to get it done. All right, so instead of urgent move, we're talking about, instead of emergent moves, we're talking about urgent moves. So this is the patient that has an altered level of consciousness, inadequate ventilation. They may be in shock or they could be in cardiac arrest, but there's no threat. There's no fire. There's no, something that's going to kill us all if we don't move the person. It's not an emergent move. It's an urgent move. So rapid extrication, lift and slide technique from the vehicle. So this is a patient that's in the vehicle, right? And you're going to apply a cervical collar because you have time to do that. An alert, stable patient suspected of having a spinal injury, and which also may be allowed to self-extricate to a nearby transfer device or stretcher, depending on what their injuries are. But again, it's somebody who's conscious, okay? If the patient is not able to self-extricate, responders can use a rapid extrication technique to move the patient from a seated position in a vehicle to a supine position on the backboard. Look at your skill drill. Okay, that's available to you, and you'll be practicing this, in the lab, when you come to class. All right, so other situations which this technique may be used, plain and simple, vehicle seen as unsafe, explosives or hazards, fire, patient cannot be assessed before being moved. These are all potential, but they're not imminent. These are just things that are potential, not that it's happening. The car is not on fire because you're putting on a seat collar. You're taking a little bit more time than the emergency move. Patient cannot be assessed. Patient needs immediate intervention to get in supine position. Patient has a life-threatening condition requiring immediate transport. The patient blocks access to another seriously injured patient. Non-urgent moves. So these are non-urgent. You've got all day to do this. Okay, not a big deal. Extremity lift is number one. That's an easy. Skill drill 8.3, look that over. This is how you do it. It's a very simple process, but do look at that skill drill 8.3. And also look at all the other skill drills, 8.1, 8.2, and the rest of them as well. But this is the specific for non-urgent moves, extremity lift. Equipment, we talked about the wheeled stretcher. This is a high Fowler position. Okay, he's sitting completely upright. That might be somebody that's having some respiratory difficulty. Notice that the stretcher is all the way up. You have this particular EMT that's got both hands on the stretcher. He is the pusher, and this person is using the handlebar at the end. He is the guider. Okay, it's not pulling, he's guiding. All right, you don't pull because that's bad on your back. This person's doing all the pushing. He's the motor, and this guy's the driver. General features: specific head, end, and foot end, strong rectangular tubing, retraction guardrails, undercarriage pneumatic, fluid resistant. You're going to get your stretcher training on new types of stretchers with Coastal. They'll come by and they'll do a demonstration with one of their vehicles, or if they cannot for that week that you have this particular class, you'll do it on a clinical site with them. They'll show you how they work, be familiarized with them. The stretcher that we have here is an older stretcher, which you might see one day, but it does not self-load itself. You have to load it along with another person. So we're going to show you both, but here's the general features. I will tell you the one thing that's important: anything that is red, don't touch it unless you know what it does, because it does something. Those are operational colors. It will let the stretcher down or let the stretcher up, or head up, head down, that kind of stuff. If it's red and you don't know what it does, don't touch it. Ask somebody. All right, so this is what we were talking about earlier, transferring a patient. They're putting a sheet under this patient. As you can see, they log roll her, they put the sheet up underneath, and then they will pull the patient over on the sheet. You can see here that these folks are up on the bed. So once they slide her this far, they get on the bed, they slide her the rest of the way on. It's a very easy thing. It's called a drag or a transfer draw sheet method. So it's easy, good stuff to do. You'll be doing a lot of that in your clinicals. Another option to move the patient from the bed to the stretcher. assist them to the edge of the bed, place their legs over the side, and help them to stand up and sit down on the stretcher. Pivot them and sit down. That's fine. That works too. Patient's conscious and has no trauma. No problem whatsoever. Assist them to get out of the bed and sit down on the stretcher, and then put them, lay them down onto your stretcher. All right, to move the patient from ground or floor onto a stretcher, there's a couple of different ways to do that. You can use your log roll, you can use a scoop stretcher, those kind of things, or you can do a direct lift like what they're doing here. They got the patient on a lifting device, which looks like a blanket. We also have what's called a mega mover. We'll show you what that is in lab, that we pick patients up on, and then we put the stretcher underneath them and set them down, and they're good to go. All right, so pushing a wheeled stretcher is like what we were mentioning before, okay? Notice how I told you about the red things? There's a red handle right there. I just hot spotting it. Red handle's there, a red handle over here, this area right here. If you don't know what it is, don't touch it. Ask somebody, okay? And it's in the elevated position, and it's in a flat position, okay? It's flat. If it's in a kind of a tilted, with the head tilted upwards more so, that's in what we call the launch position. That's before you load them into the ambulance. Okay, you're going to see one of those in a second here. Okay, that's not launch position, but notice how they've got hands on both sides. They're preparing to lower the stretcher down. One clinician pushes the head in while another one guides the foot. When guiding from the foot, make sure your arms are held close to your body. So again, pusher and driver. Okay, pusher and driver. This patient here looks like they're about to lower down in this particular position. And this is not an electric cot. This is a standard lift cot. Securing the patient to the stretcher, absolutely necessary. You've got to put the safety belts over the shoulders, around the chest, and in a 4-point harness type of fashion. You need to secure the chest, the pelvis, and the lower extremities to the stretcher. The stretcher's 4-point system that's available to you on the stretcher needs to be used every time, or what happens if you're in a car accident, anything happens to that patient, they won't assume liability for it. The stretcher companies won't. So all those have to be on there. So make sure you got all those stretcher straps in place. All right, this is that launch position. Notice that the horizontal is not there anymore. This end is up. So before you can lower that stretcher all the way down to the ground, it would have to be pushed down into the standard position. But this particular position is the position that you will use to load into the ambulance. So here's the steps to load the stretcher. Roll the front wheels to the floor of the ambulance until the safety hook catches the stretcher. Clinician in the foot then lifts and releases the undercarriage, and the second clinician lifts the undercarriage and wheels up to the ambulance floor. Now, in the electric ones, this is done automatically. Okay, a button is pushed by the second clinician, which raises that undercarriage. Let's look at the undercarriage of the structure. This is what they're talking about, undercarriage, okay? This is the electric surfaces, that's the motor, okay? This is automatically loading. The hydraulics here lift the patient up into the launch position. These are the wheels that you'll roll into the back of the ambulance. It'll be locked, so it can't go back out the other way, so the patient won't accidentally fall out of it. And then the undercarriage is lifted by that motor that's up underneath. And they're battery powered. That battery pack is up in here in this area. Good old backboard, spine boards have been around forever. They're rigid, either plastic or they're wood, most commonly plastic. Parallel to the sides, they have holes in them. Each one of these holes are where your straps go, because patients need to be strapped to the backboard. These holes up here are where your cervical immobilization devices go to. Really nice 4-man carry. You get a person, one of the clinicians on each one of these handles. There's 4 of them. Okay, there, and then over here. And you do a 4-man carry where you lift them up as a 4-man carry and you carry them. You will practice this in your lab. Scoop stretcher, they're made in 2 halves. You saw one of those earlier. That scoop stretcher, which is inserted under each side of the patient, especially patients that have pelvic fractures, and you slide the whole thing on there, lock it in place. That way you don't have to log roll. Like on the backboard, you got to log roll patients. On a scoop stretcher, you just take the 2 pieces apart and then slide it under each side and then lock it in place and lift your patient up. Vacuum mattresses, really not used in the United States. We see these quite a bit in the European EMS agencies. The problem with these guys is that if they get a hole in them, they will leak and they won't work. So many of the organizations have elected not to use these. I see them on air ambulance. I've used them in an aircraft. They're nice, but they kind of squeeze the patient, and that kind of scares them a little bit. They feel like they're being squished, kind of thing. If they're unconscious, they won't matter, but if they're not really liking it. But it does, contour to all the curves of the body. Lifting and carrying patients on a backboard, as you see here, we talked about this. This is the 4-man carry lift, or the diamond formation. The diamond carry uses 1 EMT at the head, 1 at the foot, and then 1 on each side. Good stuff. All right, so stairs, using a backboard or similar device. Be sure the patient's secured to the device so they cannot slide. Just remember, if you're carrying them up or down stairs, they're at an angle. Carry the patient on the backboard down the stairs, feet first. Okay, place the strongest EMT at the head and the foot ends. Taller person should be at the foot end. All right, so there's a stair chair. It is a device that you put the patient into the chair itself, and it will negotiate the stairs either by power motor or it gives assist. It gives spring-loaded assist to help you to bring them down or take them up. If you have to go upstairs to take them back to their room after they've been discharged from the hospital. It's used to carry when the patients are conscious. Bottom line, if their condition allows them to be sitting. Okay, there's a transfer from a chair over into a stair chair. You can see an EMT up under the patient like here. Notice that his body mechanics, he's leaned way forward. I don't like this position. I would probably change this a bit. I'd have the patient stand up and then sit them down into the chair, get the chair behind them. This is a risky move for the back. Neonatal isolette. Sometimes you may be involved in this kind of transport. The isolette has a baby on the inside. It straps to the stretcher, and it protects obviously for the child from any noise, drafts of air, infection, and excess handling. So it's a good thing. And you might be involved in this if you're doing ALS critical care transfers. Binder lifts. For patients with non-traumatic injuries who do not require spinal motion restriction, a binder is wrapped around the patient's torso. It has handles for you to pick them up and lift them. You guys will practice this with the Mega Mover, which is really, really nice. It can carry a lot of weight. Slip patient movers, they're composed of smooth material that seals an inner layer of fluid, reduces friction. Patient is rolled onto the slip and then pulled by a draw sheet across the slip. We like slide boards, it's plastic, but this is another method. There you go. Okay. Portable folding stretchers. This can be folded. It's got handles on all the other sides. And this, doesn't have anything in it other than the material. So you put the patient on. This is very similar to our Mega Movers. This is probably the military version of it, looking at the logo and stuff, I'm pretty sure it is. It's American Rescue. They create a lot of materials like this. Flexible stretchers, okay, this is the good old sliding stretcher, and the sked is what we always call them. Can be rolled up around them like a burrito, so it keeps them safe on the inside. Really good for dangerous hoisting type of operations to get them from off, high angle rescue kind of stuff. Basket, the old Reeves sleeve. Oh my goodness, or Stokes basket, excuse me. Stokes basket has been around forever, since the 70s, the 60s and 70s. It's still in use today on a lot of oil rigs and ships to get patients off of the ship or off the rig into a helicopter. Really good, easy to use in this application because they're down somewhere in a canyon and they're going to helicopter evacuate. They'll get the patient in there, get them well strapped in, and then connect into the leader lines that go into the basket where the helicopter can lift them up. Okay, short backboards. This is a KED, Kendrick Education Device. It's these are wooden slats that are inside this vinyl casing. Originally designed for NASCAR by Dr. Richard Kendrick. Nice guy. I've met him a few times, and he invented this for the NASCAR circuit to be able to get drivers out of their cars because they don't have doors and they have big frames, and so you can't really cut through them. You need to pull them out through the roof area. So, and they stabilize the head, the neck, and the torso. So if they got a suspected really bad spinal injury, they have somebody in a car and they're in a lot of pain, but it's not an emergency, because in an emergency, this takes time to put on. You need to have time with this. You just have a patient that has pain, and there's no threat whatsoever. But you can use this to package them up nicely and keep their spinal column in immobilization status. You can also use this for pelvic binding, and you can also use it for pediatrics as well. So, decontamination. You have to decontaminate equipment after use to prevent the spread of disease. Know and follow your standard operation procedures for disinfecting equipment after each call. Code of Federal Regulation CFR 1910 requires you to clean all your equipment with minimal spray and splatter. So make sure that you pre-clean it and then clean it. Just don't stick it up on a wall and hose it down with a garden hose. Not a good thing. Know your local operations procedures for decontaminating equipment. All right, so here we go. Let's do a review and see what we've learned. All right, so what's the first rule of lifting? What is the first rule of lifting? First rule. All right, so if you answered B, you are correct. Keep your back in a straight, upright position and use the powerful muscles of your thighs, powerful muscles. There's your rationale. When lifting a stretcher using the power lift, you should. You can do this. Remember the power lift? Think about it. If you'd answered C, you are correct. Use that power lift. Grasp with your hands. You got that power lift going on. There's your rationale. It is impractical to apply a vest type extrication device on a critically injured patient to remove them from a wrecked vehicle because it, A, B, C, or D. If you said A, you are correct. It takes too long. If they're critical, you just need to get them out of the car as soon as possible. Don't use the KED or the vest type of extrication device. There's your rationale. Proper guidelines for correct reaching include all of the following except So, proper guidelines for correct reaching include all the following except. Alrighty. If you answered D, you are correct. No more than 30 inches. Somewhere between 15 and 20 inches is the recommendation. Now, is it good to twist your back? Absolutely no. There's your rationale. You never, you never, ever, twist your back. So don't do that. So, that's one of those things that you don't want to do. But when we're talking about reaching, all right, reaching specifically, no more than 30 inches. No more than 30 inches. I know I don't like A either because it does say avoid twisting your back, and that is true. But we're specifically talking about reaching. Trick question. Let's go to the next one. 5. An injured hang glider is trapped at the top of a large mountain and must be evacuated from the ground. Terrain is very rough and uneven. Which following devices would be the safest and most appropriate to use? Okay, hang glider trapped top of a large mountain. Okay, what do you think? If you answered B for basket, you are correct. Very good. Yeah, Stokes basket. We saw that. We even talked about that. Here's your rationale. When 2 EMTs are lifting a patient on a long backboard, they should. 2 EMTs doing a lift. If you answered D, you are correct. Strongest person is or EMTs at the head of the board. Bingo. Beautiful. Rationale. Which of the following techniques is considered to be an emergency move? Emergency move. If you answered C, you are correct. Da, 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 da. Firefighter's drag or one-person technique. Anything that you're doing to move the patient in that kind of position is going to be an emergency move. Here's your rationale. Number 8, to extract a patient from the basement of a building, you must transport the patient up a flight of stairs. In doing this, you must ensure that blank. So you're transporting up the flight of stairs, not down. Up. If you answered A, you are correct. Always. So you're not going to go up the stairs with the patient's head down at the feet, down at the guy at the bottom. That's not going to work. Head first when you're going up. Feet first when you're going down. Very good. Your rationale. If an injured patient needs to be moved but is not in immediate danger from a fire or building collapse, you should first do what? You should first do what? What's most important there? If you answered B, you are correct. Airway, breathing, circulation. Check their ABCs, okay? If they're not emergent, let's see how they're doing before we start toting them around, because you may be toting them around for a bit. Here's your rationale. Number 10, the rapid extrication technique is a rapid extrication technique. If you answered D, you are correct. Okay, it's a seriously injured patient. You need to get them out of sitting position so you can get them supine on a backboard. so you can start working on them. You put a C collar on them and rapidly get them out. Okay, it's not the emergent move, it's the urgent move. There's your rationale. Okay. With that, thank you very much. I hope you learned something. Have fun doing these skill drills in lab. It's a lot of fun. You'll get to go outside. You get to work around an ambulance, loading the mannequins in and out, picking up mannequins, picking up each other. So have a lot of fun, and we'll see you in lab.